Danoob Dalili from London, who will give us a talk about image-guided injections for facet joint pain with evidence-based updates.
Just a minute. Apologies, I did test that it would work beforehand, but I'm going to put my laptop in just to be sure that the videos are working. Okay, great. So I'd like to thank Dr. Ahmed Kamel and Mohamed Fawzi for the kind invitation just to share our experience on how we treat facet joint pain, and just would like to share a new established procedure that we've been doing now for 5 years. So hopefully this will be interesting, and hopefully some of the papers that I'm going to share are going to be free to download as well, and you can take this home and read at your leisure. So chronic back pain is a leading cause of disability and work absence. Many of us in the room are going to suffer from facet joint pain in our lifetime, so about 40% prevalence. There's no real standardized treatment for this kind of pain. We typically use anti-inflammatory drugs, muscle relaxants, physiotherapy. We're noticing more and more patients on weight loss jabs are having problems with back pain now as well, because there's a lot of muscle wasting from around the spine. So it is a growing problem globally. We find that these positive diagnostic facet joint blocks that we do in our practice, or medial branch blocks, these help identify the origin of the pain, and then we could go on to providing neurolysis or ablation of the nerves. So the facet joint itself is a zygapophyseal joint. It's a synovial joint surrounded by a joint capsule. We've got two articular surfaces covered with cartilage, and this is then as a joint prone to wear, and then arthritis, so subchondral sclerosis, osteophytes, and effusion, and also implicated in various inflammatory arthropathies. So being aware of the orientation of these medial branch nerves is important. This essentially is where we want to land our needle tip if we're doing a branch block, rhizolysis or cryo. So being aware of the anatomy and the variation is quite important, and that's shown there on that diagram as well, just in the top right. So seeing the nerves come off and just having an idea of where we want to land on the transverse process is quite important, just to have, in our awareness of. In my practice, I examine each patient at the consultation. We want to establish the level of pain and the nature of the pain. This is really crucial for appropriate patient selection, and facet joint pain radiation typically occurs in that dark blue area, but can also radiate down to the buttocks and occasionally below the knee. So less commonly, this radiates to the groin anteriorly. And what we try to do is do 2 therapeutic blocks. If the pain persists, then we can offer cryoneurolysis in the outpatient clinic, and I'll show you how we do that. So we know that the orientation of the facet joint varies amongst different regions in the spine due to the distinct motion and the stability requirements. So we typically understand that the sagittal plane, it limits axial rotation, where the coronal facets limit flexion and extension. So these are the mechanical consequences. And the facet joints themselves, we know, bear 15% of the load on the spine, and 85% is absorbed by the disc. But these changes dramatically change with degenerative disc changes. So it tends more towards 45% load on the facet joints. So there is a linear correlation between the degree of disc degeneration and loss of cartilage coating the facet joints. We have moved away from the more traditional imaging techniques such as plain film radiographs, and now we favor more functional imaging techniques. So CT and MRI really permits very clear visualization of the degree of joint space narrowing, ankylosis, osteophytes, also T2 weighted fat saturation sequences that you can see in the middle image there. Seeing inflammation around the joints, and as well as that functional imaging, so SPECT CT, we can really identify pain generators. There are various classifications with CT and MRI. I tend to keep it very simple. So there's the Weisstrup classification, which uses CT grading, but then on MRI you have Grogan's classification. So just being aware of these is very important. I tend to just stick to mild, moderate, severe, and not tend to overcomplicate it. So both CT and MRI have their advantages. Obviously, the lack of radiation with MRI, but it's also important to note that severity is often underestimated, irrelevant of which modality we use. Some do advocate these fat-suppressed T2 sequences if symptoms aren't explained by conventional sequences, and that's very useful to identify the exact joint, but we can also use SPECT CT for that. So here's an example. We've got two sagittal sequences which don't show very much, but then we have the fat-saturated sequences where we can clearly demarcate the inflammation around the joints there. So you can just scan the QR code for that paper, but how do we, conventionally we'd use facet joint injections with fluoroscopic guidance or medial branch blocks. We use fluoroscopy for that. And then, we've moved on to CT-guided procedures as well. Very accurately, we can determine the position of the needle and any surrounding structures. And this is, how we typically do CT or fluoroscopy-guided injections. But what I'm going to show you now is the possibility of doing this without radiation. So what if we could do this seeing the muscle layers, the bone, the nerves, the blood vessels? What if we could do this without administering contrast? What if we could do this without radiation in the clinical setting away from the hospital? As well as that, seeing the needle in real-time guidance. So there are some drawbacks, obviously, using ultrasound. Patient habitus, if they have post-operative, scoliotic patients, the lack of the epidurogram to be definitively sure where the needle is. And as well as that, there is a learning curve. But there is a lot of evidence growing for the use of ultrasound for these sorts of procedures. And this will only improve and increase with further advancements and as fusion technology and artificial intelligence plays a more central role in imaging. So this is a paper, for example, we've done between two big societies, so the European Society of Musculoskeletal and also of Neuroradiology. And this was a Delphi consensus paper where we've looked at all the evidence for all the different imaging modalities. And what we really found is that statistically the benefit of ultrasound versus other techniques is equivocal. So you get very similar patient procedure time, pain scores as well, almost identical. So there really isn't a difference in what imaging modality you use, as long as the correct technique is utilized for any of these. So ultrasound is a really interesting field for this. We can do it either with fusion or without fusion. With fusion, the benefits obviously is we accurately can see the tip of the needle, especially in deeper structures, especially when we're doing nerve root blocks as opposed to just facet joint injections. But obviously non-fusion, we don't need to have the magnets, the fancy equipment, the more expensive needles. So in our practice, we use both a combination of fusion ultrasound and non-fusion, depending on the type of injection. Very typical drugs we use, so we've moved away from Kenalog now as it's been discontinued. We tend to use dexamethasone or depomedrone if we're doing a facet joint. As well as that, we use bupivacaine and lidocaine just to numb the skin. And you can see here, this is one of the transducer radiofrequency needles we use, and we can then attach any type of needle or device to that and have an accurate representation of where the tip is, particularly for cryoneurolysis, which I'll show you. So that's the typical sterile field that we have. I have no affiliations, but we tend to use more GE's equipment. They have a very nice high-frequency probe, which we utilize in our practice, and we use this VNav software. So this is for nerve roots. We can have a virtual needle navigation device, and also we have the magnet next to the patient with sensors attached and within the probe, and that allows us to identify where we are. Crucial for ultrasound is patient positioning, so having the probe midline in the longitudinal plane, and then we scan from up to down, left to right. We want to identify anatomical landmarks, and that will allow us to plan and fuse the images together. So typically we use MRI. We can use MRI, any MRI that the patient's had, or we can use CT. And we use the spinous processes and then define the facet joints using normal anatomy. So obviously we try to find L5S1, and then we can identify where the transverse processes are, if we're going to do a rhizolysis or cryoneurolysis, or the facet joints themselves, like you can see here in this schematic, if we want to do an infiltration. We can also do it in this plane. So here you can make out the vertebral anatomy very well. We can position the needle. We can identify all of the structures, and again we can either do a facet block, medial branch block, or a cryoneurolysis procedure. So for fusion, we register the images like you can see here on the left. We do this in real time utilizing the patient's own anatomical landmarks. We then identify and position the target, and then we use this VNav, either the VNav tracking needle, or here you've got the cryo probe, which I'm now fitting to the tracking needle, and allow us to accurately determine where the tip of the needle is in a sterile fashion for when we go ahead and do the procedure. So here I'm just preparing that needle, and hopefully in the next slide you'll see how we do the procedure. So typically for an injection of any sort, we'll give some lidocaine in the skin, and then around the site that we're going to inject, we wait 30 seconds, and then we test lower limb neurological function. And here is an example of us doing the fusion for the L5S1. So we've marked out the target point, which you can see in real time, and then we place the needle, and then shortly here you'll see hopefully some movement here. So this is us in the inferior joint recess just doing an infiltration on this side at L5S1. And this is without needle tracking. So this is without the fancy equipment. It's literally the ultrasound, the probe, the software, and the recent MRI. And here we have L4, L5, and a medial branch block that we're doing. We're doing this in the axial plane. Again, similar principles. And here we have 2 target points, so this is a 2-level infiltration that we're doing, and you can mark as many targets as you'd like. And these are just several examples, and this is an example of an L4 nerve root block. And we want to identify where the target is, and here we can see there is the target, and we position the needle, which you'll see on this image, so that's the needle tip. And we can see in real time as we're advancing the needle towards the target, very simple to do, and quite safe as well. So this is what we routinely do in the clinic with all of our spine injections, and we can determine the predicted angle of the needle. So it's very good, particularly for the S1 nerve root, where you have to come in at an angle. So literally within millimeters of the nerve is how we're doing the infiltration. So here's an example of the S1 nerve root. So you're getting a really nice craniocaudal angle, which is typically quite tricky to access with fluoroscopy, but with ultrasound we can do that quite easily. So just to finish, with regards to cryoneurolysis, very good innovative technique which we've now adopted and kind of pioneered for fusion. Involves applying cold to the nerve to induce denaturation. We select the patients depending on how they've responded to the facet joint or medial branch block. It's much safer, much more tolerated than rhizolysis. Typically, patients don't need sedation. It's a relatively pain-free procedure. And here is a case that I've done just a couple of weeks ago. So we've got the this is the probe that we tend to use. It's a 4 to 20 frequency probe, so quite a good bandwidth of frequencies that we can see quite deep into the body. And here I'm positioning the cryoprobe, and this is the images that we tend to see. So I've marked up already, and then in real time I can see the trajectory of the needle and where I want to advance the tip of the probe on the transverse process to then do the cryoneurolysis. So I do this at 2 or 3 levels, and the patient's completely awake, simply with local anesthetic. And you can notice there's no radiation, there's no X-ray machine, there's no staff needed. I just have one helper, but we don't need to have extensive amount of tools. So it's quite a nice procedure to do in the clinic. And this is just a magnified view of an L5S1 fusion case that we're using CT. So we don't have to just use MRI, we can also use CT, and CT has very thin slices. So an excellent method for that. Following patients up, it's really important for us to understand how useful the procedure has been. So we do this routinely for all of our patients. So in summary, I hope you can see and understand and appreciate now that ultrasound is a fantastic tool to use for these patients. We've trained many, many doctors, pain physicians, radiologists, surgeons to do these sorts of procedures using very lifelike models. So this is a course that we teach, and we welcome you to join us in May. So thank you very much for your attention.
Thank you very much, Danoob. That was an excellent talk. Does anyone have any questions for any of the speakers on today's session? Just raise your hands and we'll get a microphone. Would any of my colleagues have any questions for the panel?
I'd like to ask Dr. Ahmed Zidan, first off, thank you very much for the very informative presentation. Carpal tunnel syndrome is something that, it's very prevalent in our community. Do you think this procedure will be available for more patients? How do we get patients to know about it? And how long does the hydrodissection last? How long do the symptoms resolve for?
Hydrodissection, augmented, is a good procedure. It has a good outcomes on the patient. I have many patients have prolonged relief over years. This depends on many factors. The first one, age of the patient, duration of compression, integrity of the nerve, is the patient diabetic or not, condition of the muscles. If the patient also modulation of life and lifestyle after intervention. This is the most important. If the patient turns his life from excess use of the hand and get more better habits, it will get a more prolonged period of relief. This is the first one. Second issue is the clinical background of the patient. Diabetic patient have good benefit from this procedure in relieving the pain. Regarding duration, also depend on if the يعني ده بيعتمد على مدى التزام المريض باللايف ستايل بعد البروسيدور. تمام. الحاجه الثانيه احنا المريض بيجي لنا امتى؟ دي برضه نقطه لازم نتكلم فيها. معظم المرضى بيجوا لنا مش عشان ان عنده نامنس او بيرنينج سensation، لا، المريض بيجي لنا في الكونديشن اوف نيرف كونجيشن. سو patient at this time can't sleep. انا مش عارف انام، انا عايز حل. طيب ايه النيتشر هيستوري اللي العام بيشوفه بعد ما بنعمل الانترفنشن بروسيدور؟ فروم داي 1 العام بينام، مفيش بين، نو بين فروم داي 1. النامنس start to leave the palm of the hand within 1 week. completed to the tip of the finger after after 1 month. If the patient is younger younger in age, the nerve is not, there is no, if there is no severe axonal degeneration, we found improvement of total condition within 2 days. الامباكت اوف الفينستريشن على الاوتكم بتاعت الهيدرو ديسكشن it's very good because the surgeon just decompress the nerve by cutting the transverse carpal ligament. He can deal with perineural adhesion. Hydrodissection deal with perineural adhesion. Fenestration deal with thickening of the transverse carpal ligament. So the patient العيان بياخد ال two benefits for perineural release and decompression of the and thinning out of the transverse carpal.
Thank you. I have a question for Danoob Dalili. In your experience with training people to start doing fusion imaging and image-guided interventions, what do you think is the average time for them to pick up, or how many cases? And what do you think the patient experience is when they've had ultrasound-guided image interventions as opposed to CT or fluoro-guided?
Thank you for the question. I think on average they've done there have been some papers that have been done for interventional procedures and learning curves. I would probably say, for me personally, probably about 50 procedures, I would say, with direct supervision, because it really depends. I mean, ultrasound is a skill you first need to have before applying it to more advanced techniques like this. So if you are performing ultrasound routinely, I'd probably say it takes on average 50 procedures. I think this is in line with literature. So generally with any interventional case procedure, to perform it independently, you need to have done about 50 cases. Patient experience, a lot of patients are claustrophobic, and you find that when you put them in the CT scanner, they don't tolerate it very well. So that's one of the other benefits. Patients really like the fact that they can come, be seen, treated, within half an hour. As you can see with my case, the patient didn't have to fully declothe. They came to the clinic. We saw them, treated them within 30, 40 minutes, and they were on their way. Whereas when you come to a hospital, there's all the logistics around that. Who's going to take them home, finding parking, come check into the main reception. So I think we streamline a lot of those things, which affects the patient experience, and also accessibility, because the technique that I've shown you, you can do it anywhere in the world. You just need to have an ultrasound machine and some recent CT or MRI of the patient. You don't need to have a leaded room, X-ray, or any fancy equipment. So I think those are the benefits the patients experience.
Okay, any other question? Okay, Dr. Mohammed Hamidi.
Thank you very much to all the speakers for the very interesting talks. I have two questions. The first one for Dr. Gamal Niazi, concerning the ablation of metastases. Are the metastases in the peripheral skeleton, like the limbs, also feasible for ablation? And do they carry an increased risk of pathological fracture? The second question is to Dr. Amgad Musa. Thank you very much. Excellent presentation. What are the tools that you use? Are these regular K-wires and screws, like in the toolbox of the orthopedic surgeon, or are they different? Thank you.
Okay, I'll start my answer. Metastasis in the peripheral, in the appendicular skeleton, you mean? Okay, yes, we did some cases of thermal ablation of metastasis in the appendicular skeleton, and it's whether is it in weight-bearing bone or not. Okay, so in the upper limb, I do not have much risk of pathological fracture if there is no pathological fracture from the start. If there is a pathological fracture, I do not ablate. Okay. In the lower limbs, yes, we can consider either we used to do cementoplasty after ablation of metastatic tumors in the lower limbs, or fixation, as Amgad said. Nowadays, it's much more better. It carries better results.
Thank you, Dr. Hamidi, for the nice question. I think that the tools that we use for fixation are a combination between things that we have in our interventional radiology suite, such as the bone biopsies and our ability to use advanced imaging, and the tools that are available for orthopedic surgeons, such as the K-wires and the screws and different types of screws and the different lengths, threaded, fully threaded, all these things. So I think they're available in Egypt. I know that the orthopedic surgeons do some fixations, but I know that there hasn't been a focus on patients with metastatic tumors or pathological fractures. So there is a need, and there is availability to provide this for our patients.
Any other question? So now this is the end of the session. I would like to thank all speakers and my dear friend chairpersons. I thank all the attendees, and we will move after 3 minutes to the next session. Thank you all.